Hello and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Team-Based Care for Diabetes and Hypertension. If you have questions about anything being discussed today, please call or email during our broadcast. The phone number and email address will be on the screen and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are available online. You will need to register for this program in order to access these materials. Continuing education credit has been approved for today's program for nurses, social workers, and pharmacists. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, the continuing education credit will only be awarded for 1 year for nursing and for pharmacists, expiring on May the 31st, 2017, and 2 years for social worker, expiring on May 31st, 2018. I'm Dr. Jim McVeigh with the Alabama Department of Public Health. I'm Director of the Bureau of Health Promotion and Chronic Disease, and I want to welcome our faculty presenters today. Dr. Camille Quills with the Harrison School of Pharmacy at Auburn University. Dr. Kane Eric Kirk, pharmacy resident with Central Alabama Veterans Healthcare System. Dr. Francis Connor, co-owner and clinic pharmacist at Chad's PAYLESS Pharmacy. And Dr. Christine Laird, pharmacy resident at the Joint Ambulatory Care Center at Gulf Coast Veterans Healthcare System. Welcome everyone and thank you for being here. Our first presenter, Dr. Quills, will be covering Pharmacists' Role in Diabetes and Hypertension Management. Camille.
Thank you for the lovely introduction. As Dr. McVeigh said, my name is Dr. Camille Quills, and I'm the clinical pharmacist over at the State Wellness Center with Auburn University's Harrison School of Pharmacy, and that is located down here in downtown Montgomery. And I'll be covering the pharmacist's role in diabetes and hypertension management. I first want to say that I have no actual or potential conflict of interest in relation to this program. So some of the objectives I'll be covering today is doing a brief background on diabetes and hypertension, diabetes and hypertension in the United States and Alabama, diabetes complications, how diabetes and hypertension are related, the pharmacist's role in a collaborative care team, pharmacists and medication therapy management, disease education and medication counseling, and lifestyle management counseling. So I would first like to cover what exactly is diabetes. So diabetes is a chronic condition that hinders the body's ability to use carbohydrates in food as an energy source, resulting in high blood sugar. There are two types of diabetes. There's type 1 and type 2. Type 1 diabetes is where the body's immune system destroys the pancreatic cells that release insulin, eventually eliminating insulin production. Without this insulin, the body cannot absorb sugar to produce energy. And this actually accounts for a small population of diabetics, usually about 5 to 10% of those people. And the main treatment for type 1 diabetes is going to be insulin management. Type 2 diabetes, on the other hand, is going to account for the vast majority of patients, usually about 90 to 95% of patients with diabetes. And this is actually where the body is not able to effectively use insulin, or called insulin resistance. And as this worsens, the pancreas will lose the ability to produce sufficient amounts of insulin, and that's going to be called insulin deficiency. Treatments for this are going to include both oral and injectable medications, as well as insulin. Hypertension occurs when the pressure of the blood in your vessels is going to be higher than it should be. And I'll have a little picture here to show you that. And this is going to raise the heart's workload and can cause serious damage to the arteries over time if left untreated. And so as we can see, blood pressure is going to be the measurement of that force applied to the artery walls. So what is the prevalence of diabetes in the United States? So there are about 29.1 million people, or 9.3% of the U.S. population, have diabetes. About 21 of those are going to be diagnosed as diabetics, while 8.1 million of those are going to be remained undiagnosed. Of the 29.1 million, approximately only 1.25 million of those are going to be type 1 diabetics. So again, the vast majority of the populations are going to be type 2 diabetics. Of the 29.1 million, 1.4 million Americans aged 20 years and older are newly diagnosed with diabetes each year. If we look at that into other numbers, that's about 3,835 people each day, or 1 every 23 seconds. So what does diabetes look like in the state of Alabama? So right now we have about 11.8% of people who are over the age of 18 who were told by a healthcare professional that they had diabetes. This is actually a reduction from previous years, but when we compare it to the other U.S. states and territories, we are actually ranked 51 out of the 54 states, so we are still pretty up there, even higher than the all states median. So what is the cost of this? So the estimated cost in 2012 was that diabetes accounted for $245 billion in direct and indirect medical costs. This total is actually going to increase to about $322 billion if we count individuals that are undiagnosed diabetics, pre-diabetics, or those who have gestational diabetes. And people with diagnosed diabetes have healthcare costs that are 2.3 times higher than those who do not have diabetes. And the largest components of this medical expenditures are going to be hospital inpatient care, prescription medications to actually treat the complications of diabetes, anti-diabetic agents and diabetes supplies, physician office visits, and nursing and residential facility stays. What about hypertension? So it's estimated that 67 million American adults will have high blood pressure. So that's 1 in 3 people. So one of us out of the 3 people on this panel are going to have hypertension. Only about half, or 47% of those people are going to have their blood pressure under good control. And there's many causes for this. This includes lifestyle choices, suboptimal patient medication adherence, as well as the failure to intensify therapy by clinicians, or also called clinical inertia. The estimated cost associated with this is going to be $51 billion per year, with about $47.5 billion in direct medical cost. So diabetes and hypertension is a pretty bad combination. So diabetes is going to remain the 7th leading cause of deaths in the United States, with little over 234,000 death certificates listing diabetes as an underlying or contributing cost. And many studies actually think this is an underrepresentation. Hypertension, on the other hand, is going to be the primary or contributing cause of death for more than 360,000 Americans. That's almost about 1,000 deaths each day. So diabetes is going to complicate matters even more because it is associated with some serious complications, including heart disease and stroke, blindness, kidney disease and failure, non-traumatic lower limb amputations, as well as periodontal disease. It's even more concerning when patients present with both diabetes and hypertension, especially since the risk of cardiovascular disease or an event is in itself increased in those with diabetes. And many of these complications can be reduced with good glycemic and blood pressure control. According to the CDC, every 1% drop in your A1C can reduce the risk of microvascular complications by about 37% and decrease your risk for heart attack by about 14%. Also, for every 10 millimeter mercury drop in your blood pressure, it's going to reduce the average risk for heart disease mortality and stroke mortality by about 30 and 40% respectively. So how can pharmacists help in diabetes and hypertension management? So in 2005, the Joint Commission of Pharmacy Practitioners described the role of pharmacists in its vision of pharmacy practice as pharmacists will be the healthcare professionals responsible for providing patient care that ensures optimal medication therapy outcomes. As Marie Smith, PharmD, puts it, pharmacists are highly accessible and well-trained, yet often underutilized key healthcare professionals to move us closer toward achieving better medication management outcomes for patients. So pharmacists can also serve as a resource to other healthcare providers and payers to assure safe, appropriate, and cost-effective medication use. So with the complexity of today's drug therapies and greater emphasis on patient medication safety, the need for interdisciplinary and shared responsibility between pharmacists and healthcare providers or prescribers to improve medication outcomes and manage cost-effectiveness of drug therapy regimens has become more apparent. We have here something called a collaborative drug therapy management, or CDTM for short. This is where physicians and pharmacists will develop a protocol, And some of the responsibilities that the pharmacist is going to be in charge of is going to be doing performing patient assessments, ordering medication-related laboratory tests, administering medications, as well as selecting, initiating, monitoring, and adjusting medication therapy regimens. Now, there can be significant variability in these CDTM agreements, but really the scope of the CDTM responsibilities as well as the pharmacist qualifications is going to depend on that healthcare practitioner. But what we need to consider is the patient's needs, involved drug therapies, as well as the care settings. So there are going to be key studies and there's ongoing research looking at the impact pharmacists have on diabetes management, and I'll cover some of those right now. So the first project was a pretty big project in the pharmacy world, and that was the Asheville project back in 1996. And this was an employee-sponsored pilot project in Asheville, North Carolina, where specially trained pharmacists met with employees with diabetes to educate, motivate, empower them to better manage their condition. Some of the essential elements of this project included a network of specially trained community pharmacists to whom employees with diabetes made regular visits for monitoring and counseling. The employer actually paid pharmacists for their pharmaceutical care services, and there was actually some incentives for the diabetes program participants, such as waived copays for diabetes medications as well as supplies. Now, this model typically will serve as a model for many ambulatory care diabetes clinics that are out there, and this actually served as a model for the clinic that I have at the State Wellness Center and when it comes to managing our diabetes patients. So some of the services provided by the pharmacist included setting and monitoring diabetes treatment goals, home glucose meter training, adherence strategies, physical assessments of the patient's feet, skin, blood pressure, and weight, as well as diabetes and lipid management education. And some of these patients were then referred to their physician or other specialty care, as well as diabetes education centers if needed. So what were some of the clinical and financial outcomes of this project? So we did see a mean hemoglobin A1C values and lipid levels of program participants decreased, with more than 50% of those participants demonstrating improvements at every measurement. At the first 6-month follow-up, about 23.4% more patients had optimal A1C values compared to baseline, which with a goal of less than 7%. And this actually increase trended further at subsequent 6-month follow-up visits. We did see that emergency department visits occurred at a rate that was 1/3 the national average. There was decreases in total direct medical costs that ranged from $1,600 to $3,300 per participant. And actually, one employer saw an average reduction of about 41% in program participants' sick days and estimated a value of about $18,000 for increased productivity per program participant per year. And there's also an employer return on investment of about 4-to-1 for their diabetics. So that was an example of one program. I will now talk about another program, which was the Diabetes 10 City Challenge, and that was back in 2006. And this was actually where pharmacists worked with 30 employees in 10 areas around the country. And this was actually an innovative program for employers and communities to fight diabetes and reduce healthcare costs. It was an incentivized voluntary health benefit for both employees and dependents to encourage management of their diabetes. And they actually, the pharmacists provided services that were similar to those in the Asheville project. Now, what were some of the clinical outcomes of this project? So we did see significant improvements for key clinical outcomes over 1 year. So we did see decreases in A1C. There was also decreases in LDL cholesterol. We did see a decrease in systolic and diastolic blood pressure, as well as a decrease in BMI. It was also noted that the rates of influenza vaccination, as well as eye and foot examinations were increased as well. So what were some of the financial aspects of this? So it was concluded that there was a savings of about $900 per employee in total healthcare costs over the first year. There is actually a 50% reduction in absenteeism, and there is actually fewer workers' compensation claims. There's also a high employee satisfaction rate among the program participants, and it actually had a 95% approval rating for pharmacists. There's improved quality of life, and the employees actually saved with this program from about $400 to $600 per year with the incentive, so they were actually able to save when their co-pays were waived for certain medications and diabetes supplies. Another program that was looked at was back in 2005, and this was actually looking at an employer-sponsored project in Ohio where the objective was to measure the impact of pharmacist-provided MTM or medication therapy management services on diabetes outcomes, as well as social and process measures. And some examples include smoking cessation, exercise, self-monitoring blood glucose, visiting a podiatrist or a dentist, as well as influenza vaccinations. And so the pharmacists counseled patients at 6-month intervals, and they really focused on providing diabetes education, as well as diabetes therapy and management education. They also established personalized goals for therapy for their patients. They did comprehensive medication reviews, and they also counseled extensively on lifestyle choices and medication adherence. Whenever recommendations were made to the patient as well as the prescribers, they usually would discuss them with the prescribers as well as the patients whenever changes were needed and whenever they were warranted. So the clinical outcomes showed an A1C. We actually saw improved glycemic control in those higher risk patients or patients with a baseline A1C of greater than 7 at both 6 and 12-month intervals. And we also saw that patients who had an A1C of less than 7 actually maintained their glycemic control. With their blood pressure, there was an overall systolic blood pressure decrease of about 5 millimeters of mercury. And patients with a higher systolic blood pressure at baseline or a systolic blood pressure of greater than 130 showed significant decreases throughout the study. So we saw that at 6 months and almost double that at 12 months. And it was also noted that there was a significant favorable change for services or recommendation of additional care to podiatrists as well as dentists after the first year. So the researchers actually noted in this project that pharmacists can have an impact in educating and guiding patients in receiving additional care when it is recommended. So as you can see from these collaborative care studies, it is evident that pharmacists can have a tremendous clinical impact on not only glucose control but other significant areas, such as cardiovascular risk and other complication reductions, thus improving overall patient outcomes. This actually progresses further to financial savings and ultimately reducing the cost to the healthcare system. So now I would want to kind of focus on the role that pharmacists can have and describe some of those roles in more detail. So as one of the most easily accessible healthcare professionals, pharmacists have become necessary tools and have the necessary tools and knowledge to implement timely screening and effective prevention initiatives. Patients will often see their pharmacist 7 more times than their doctor. And pharmacists are often available all day and into the evenings and weekends with no appointment needed. Pharmacists can have a significant role in medication management of patients with diabetes and other comorbidities such as hypertension and dyslipidemia. And this is not just limited to medication counseling. This can include designing, modifying, and as well as optimizing medication regimens. This could also be assessing adherence to medications and providing strategies for improvement. This could be recommending cost-effective medications as well as performing drug interaction reviews. This could include discussing the rationale of medications choices with their patients, as well as counseling on proper medication use, administration, storage, as well as any side effects to expect. And the pharmacist can also provide disease and lifestyle management counseling or education. They can provide recommended vaccinations, as well as refer patients to additional care such as podiatry, optometry, and dentistry. So what pharmacists can provide is the continuity care by following the patient throughout the year versus in between physician visits. Sorry, I misspoke. The pharmacist can provide continuity care by following the patient care progress between physician visits. So instead of seeing patients every 3 to 6 months, the pharmacist will see them more often, usually at every 1 month period. So we'll be able to follow up more with those patients. So like I said, pharmacists can play an integral role in managing patients' medications and can significantly benefit outcomes. Some of the ways that pharmacists can assist in medication management is going to consist of working with a healthcare provider in designing a medication regimen and monitoring plan that will provide the most benefit to the patient. We can recommend adjustments to medication therapy during follow-ups, especially when that patient is not at goal. We can also optimize medication regimens for specific patient subgroups based on comorbidities. So, for example, we can recommend an ACE inhibitor or an ARB for patients that have concomitant hypertension, or we can initiate a statin for those with dyslipidemia. We can also simplify or manage complex medication regimens, so we can always switch a patient to a combination medication to reduce that pill burden, or we can switch to an extended release formulation, especially if they're experiencing any side effects from a certain medication. We can also assess their adherence, and we can also provide them strategies on how to improve on that. So we can recommend setting an alarm for themselves or putting it by their bedside to remember to take their medication. If cost is an issue for the patient, we can actually recommend less costly but just as effective medications for their regimen. And we can also make recommendations on manufacturer coupons, especially if that is a brand name only expensive medication that can really reduce that medication cost. Pharmacists have the knowledge and ability to detect drug interactions that could lead to adverse events as well as adherence issues. So we can make recommendations to modify that regimen or tell them to stop an herbal supplement if that appears to be interacting with their medications. I really believe that in order to make informed decisions about their medications, patients must be educated on their medical condition. And so they need that basic understanding, and pharmacists are a great resource for that. Again, we are easily accessible, and we can provide these patients with accurate and easy to understand information on diabetes and hypertension, as well as other disease states. Usually, patient education is going to consist of teaching them about the disease, associated risk to their health if it's improperly managed, available treatments, as well as treatment goals. And whenever you educate the patient on these things, you can actually open up the discussion for the rationale of certain medications. So that will open up that discussion with the patient. So as far as medication counseling, given that we are the medication experts, we can easily discuss with the patient the appropriate use of their medications, how to administer, how to properly store, as well as on any potential side effects. And as I mentioned, we will typically see the patient 7 more times compared to when they see their physician. We can follow up with these patients, ensure that they're taking their medication appropriately, and make sure that they're not having any side effects and make recommendations at that time. Since we are easily accessible, and I can't really stress that enough with this presentation, we can provide those patients with accurate and easy to understand information on how to manage their diabetes and hypertension with lifestyle management and provide other services. So we can talk to them about nutrition. So we can counsel patients on monitoring their carbohydrate intake. We can also talk to them about a variety of different foods that they can eat. For example, with my diabetes patients, I really talk to them about carbohydrate monitoring, and that has really made a difference in their A1C levels. If they have hypertension along with their diabetes, we can talk to them about limiting their sodium intake as well. We can talk about physical activity and those goals, and we can also talk to them about ways to lose weight. And a lot of pharmacies are now offering weight loss management programs, and that's going to provide them with a good accountability for weight loss. We can also train our patients on how to use glucometers. And so I will usually recommend for patients to use their glucometer if they're newly diagnosed, or if they are on insulin therapy, or if there's a change in their medication, if they're pregnant, as well as if they have any acute illnesses. I like to encourage them to use this method because this is going to let them know how foods are affecting their blood sugar, but also lets them know if their medications are actually appropriate and working for them. And I usually will tell my patients, this is going to allow you to control the disease and not to let the disease control you. With a variety of different meters out there, we are a great resource to teach these patients on the right type of meter for them. You know, so if you have somebody that's technologically savvy, they might want a more complicated meter, or if somebody's really not understanding, you can get them a simpler meter. This is also a great opportunity to teach them about hypoglycemia and potential treatments. Today, most pharmacists are actually offering vaccinations at many of their pharmacies, and so this will give us an opportunity to be able to educate about certain vaccinations they need to get, as well as provide it there to them at that visit right then and there. We can also recommend them to specialists, and so at my clinic I will perform foot exams, so oftentimes I will have to recommend them to a podiatrist because I find some abnormalities in their foot exams. Or if they haven't been up to date on their eye exams, I will recommend you should make an appointment to see your eye doctor right away. So this will open up that opportunity to discuss additional care that they'll need. Also, many employers are implementing biometric screenings. So with the state, we have these health watch screenings, and pharmacists can actually perform these, and this will open up the door to discuss the different disease states that are usually covered on these biometric screenings. So this will be hypertension, diabetes, as well as dyslipidemia and weight. And so this will help open up that discussion, and we can talk about lifestyle modifications as well as medication management. So with all these aspects to consider, pharmacists have become an integral part of the healthcare team in providing optimal care for not only diabetes and hypertension patients, but for many other patients. And so we provide clinically significant benefits in diabetes and hypertension when we're integrated into a healthcare team. We assist in providing optimal medication management. We're easily accessible health experts that are able to provide health education and medication counseling. We provide various types of lifestyle management, and we can also provide various types of services that are going to be essential to diabetes and hypertension care. And here are some of my references.
Thank you so much. And our next presenter, Kane Eric Kirk, I'll turn it over to you now.
Okay, good afternoon, everyone, and thank you for having me here today. I'm Dr. Kirk. I'm currently a PGY1 pharmacy practice resident at the Central Alabama Veterans Healthcare System in Montgomery, Alabama. And I'll be presenting the results of a project to evaluate the impact of a hypertension shared medical appointment on clinical outcomes and medication adherence in a Veterans Affairs healthcare system. And I think this is just one example of the many ways that pharmacists can have a positive impact on providing patient care for patients with chronic disease states. I would start by disclosing that neither myself or the co-investigators have any disclosures to report. And this project was performed as a quality improvement project to improve patient care at the Central Alabama Veterans Healthcare System. And upon further review by CAVIS leadership, it was determined to meet the guidelines for IRB review exemption. And the views presented in the presentation today are those of myself and the co-investigators only, and are not intended to represent the views of any facility with which we hold an affiliation. This is just a list of some of the acronyms that we'll talk about today in the presentation. I'll just point a few out here. CAVIS refers to the Central Alabama Veterans Healthcare System, which is the institution that the project was performed. The PDC refers to the proportion of days covered, and SMA refers to shared medical appointments, and both of these will be covered in further detail later in the presentation. CAVIS is an integrated health system offering both primary care and acute care services across multiple locations in Central Alabama and Southwest Georgia. This project took place at the Montgomery VA Clinic and the Fort Benning CBOC, or community-based outpatient clinic. Both of those clinics provide outpatient primary care services to veterans in the community. According to the Centers for Disease Control and Prevention, the leading cause of death in the United States is cardiovascular disease, which includes both MI and CVA. These events are often attributable to underlying chronic disease states such as poorly controlled hypertension, dyslipidemia, and diabetes. Poor blood pressure control is attributable to a lack of patient understanding as well as poor adherence with their prescribed medication regimens. We know that patients with good medication adherence decrease medical costs and rates of hospitalization and have shown as much of a 45% improvement in blood pressure control compared with those veterans who have poor or moderate adherence to their prescribed antihypertensives. And it's estimated that only 70 to 75% of veterans have appropriate blood pressure control. And within the VA healthcare system, pharmacists play an integral role in the management of the previously mentioned chronic disease states. There's several influencers of medication non-adherence. Some of the barriers to medication adherence are owned by the patient, as well as some that are owned by the provider. And so it's important in designing a plan to improve medication adherence to consider some of the barriers that patients and providers face in improving medication adherence. And some of the factors are also owned by both the patient and the provider, mainly non-involvement with medical decision making. The SMA model provides solutions to medication non-adherence in ways such as including patients in the decision-making process, improving access to care, and providing patient education and medication counseling. Additionally, our SMAs are focused on prescribing in accordance with nationally published clinical practice guidelines. So typically in the SMA setting, you would have 10 to 15 patients who meet with a team of interdisciplinary providers to provide support for behavior change and improved clinical outcomes. This team of providers may include typically a provider such as a physician or a nurse practitioner, pharmacists, nurses, dietitians, psychologists, as well as social workers. The goal in this setting is to exchange health information, have the patient adopt lifestyle modifications, and make therapeutic interventions as part of a comprehensive care plan to achieve improved clinical outcomes. For the SMAs that take place at the SMA, oftentimes the pharmacist acts as the provider and the medication changer for the veterans enrolled in this group setting. SMAs have been utilized across the country, and we know that there's been documentations in the primary literature that there's improvements in the A1C, LDL, and systolic blood pressure of patients who participate in such programs. However, there's no reports in the literature, to our knowledge, of SMAs and determining the influence on medication adherence. Prior to this project, CAVIS was performing SMAs to improve clinical outcomes for pain management as well as diabetes. The purpose of this project was to implement a pharmacist-run SMA to improve veterans' access and quality of health care. We had the aim to improve adherence to prescribed antihypertensives as well as reducing systolic and diastolic blood pressure. We also hope to provide quantitative evidence for the quality of healthcare services offered to veterans enrolled in care at CAVIS. The objectives of the project were to assess the differences in the proportions of veterans considered adherent to prescribed antihypertensive medications between a baseline and post-intervention analysis periods, to assess the difference in the proportion of veterans with adequately controlled blood pressure from baseline throughout the intervention period. And secondary objectives were to assess the mean change in systolic and diastolic blood pressures from baseline throughout the intervention period. Veterans were included in the SMA if they were prescribed 2 or more antihypertensive medications and had documented systolic blood pressure greater than 140 or diastolic blood pressure greater than 90. They also had to be enrolled in healthcare at CAVIS and be 18 years of age or older. Veterans were included in the final analysis if they had attended 2 or more sessions of the SMA. We identified 4 providers across the CAVIS health system and asked for their permission to enroll veterans into the SMA from their panels, and all 4 agreed. From these 4 panels, 15 patients of each panel were enrolled into the SMA. And each provider's panel had a corresponding SMA, so we were running 4 SMAs with 15 veterans enrolled in each SMA. The pharmacist acted as the provider for this group, and each SMA was to meet every month for 4 months. The pharmacist worked alongside nurses, social workers, dietitians, and psychologists who all provided expert advice for the management of hypertension from their respective fields. Pharmacists acted within their defined scopes of practice to initiate new antihypertensives, increase or decrease medication doses, and discontinue prescribed medications as appropriate. Each group met for an hour and a half And the first half of the meeting was designed around a topic discussion and Q&A session. And then the second half of the meeting was designed for each veteran who attended that session to be one-on-one with the pharmacist to go over their home blood pressure readings and to make medication adjustments as needed to improve the control for that veteran. The monthly topic discussions included talking about things such as what is hypertension, what happens if blood pressure is poorly controlled, as well the dietitian would come and she's talked about ways to improve their eating habits and how that influences their blood pressure. She also presented the DASH diet plan, or dietary approaches to stop hypertension. And psychologists and social work paid visits to the group to present stress management and techniques that they can use to improve their blood pressure control. Additionally, at each meeting, veterans were provided blood pressure monitors and medication organizers as needed so that they could assess their blood pressure control in the home setting, as well as track their medication adherence. Data was collected during a baseline analysis period and throughout the intervention period, and all data was obtained from the electronic medical record. The PDC, or proportion of days covered, was calculated using refill history available from the outpatient VA pharmacy database, and antihypertensive medications that were included in this calculation were ACEs, ARBs, calcium channel blockers, beta blockers, and thiazide diuretics. Adherence to medication is defined if the PDC for the period that you're looking at is greater than 80%. The average of the 3 most recent blood pressures during the baseline and throughout the intervention period were collected from the EMR to determine the proportion of veterans meeting goal blood pressure. And for the purposes of this project, we defined goal blood pressure as systolic blood pressure less than 140 and diastolic blood pressure less than 90. Demographic data was also collected and included age, race, and sex. Here are the statistics that was used to determine the differences between the baseline analysis period and the intervention period. Overall, there were 21 veterans who were included in the SMA and attended at least 2 or more of them, so they were included in the final analysis. The average age of those veterans was 62 years, and 81%, so the majority of veterans who were included in the baseline analysis were African American, and all of the veterans included in the baseline analysis were males. On average, there was 1.8 pharmacist interventions performed per patient, but this does not include medication counseling and patient education that was provided at each of the SMAs. In total, there was 37 pharmacist interventions performed for the 21 veterans included in the final analysis. The majority of those interventions included dose titrations, and we also saw a high number of veterans being issued a blood pressure monitor as well as the initiation of new medications. And I would point out that for some veterans, the pharmacists determined that it was appropriate to either discontinue the antihypertensive medication or to actually decrease the dose of the medication. For the results, the proportion of veterans with controlled blood pressure improved from the baseline period to the intervention period, with 14% of veterans determined to have controlled blood pressure at the baseline period, and that increased to 43% who had controlled blood pressure throughout the intervention period, and this was statistically significant. The proportion of veterans considered adherent to their antihypertensive medications did not differ significantly between the baseline and intervention periods. Systolic blood pressure decreased significantly for 76% of veterans enrolled in the SMA, and the average decrease was 8 millimeters of mercury. Diastolic blood pressure also was reduced in over half of the veterans enrolled in the SMA, and the average decrease of the diastolic blood pressure was 1.5 millimeters of mercury. We conclude that a pharmacist-run SMA significantly reduces systolic blood pressure and increases the proportions of veterans with controlled blood pressure in a VA healthcare system. And we believe this can be extrapolated that a pharmacist-run SMA may decrease the risk of adverse outcomes resulting from poorly controlled hypertension, such as MI and stroke, in the veteran population. We would like to point out that the change in adherence from the baseline throughout the intervention period, we believe, is a conundrum that we found due to the fact that the study period, or the project period, was 4 months, and we were looking at 90-day supply of medications filled during that 4-month period. We also failed to consider the fact that medication tapering and discontinuations could occur at the recommendation of the pharmacist, that the baseline adherence rate of veterans taking their antihypertensives was actually greater than 90%, and also overall we had a low number of veterans who were included in the final analysis. We'd also like to point out the important fact that this project demonstrates that good adherence to possibly inappropriate medication or an inappropriate dose of the medication still results in uncontrolled hypertension. So this demonstrates one opportunity for the role of pharmacists to be incorporated into primary care teams to ensure patients are receiving the appropriate medication at the appropriate doses. There's a number of strategies that we encountered to the implementation of a SMA in our healthcare system. One of the most important points was to have provider buy-in. We saw that providers who were more bought into the program, their veterans were more likely to attend each group session than those providers who were less bought into the program. And also the importance of taking an interdisciplinary approach to care. So the pharmacists are the medication experts on the team of interdisciplinary providers. And so for that reason, they do not want me presenting on the diet and the foods that they are eating. And so for that, we had to rely on our dietitians friends. And additionally, pharmacists are probably some of the most stressed out people on the interdisciplinary care team. And so they do not want me to present on stress management. So we relied on social work and psychology for that. We also encountered several barriers to the implementation of the SMA. One of the more common was patient motivation, so we would call and ask if they wanted to attend these class sessions, and they would just say flat out no. And so actually getting the veterans to attend was a barrier. The administrative investment on the time of the resident, which was myself, so thinking about scheduling these veterans into the clinic, sending them reminder letters, calling them the day before to remind them that they have an appointment took a large amount of time. And then also provider status. So within the VA, pharmacists have the authority to make medication changes, to initiate new medications, to discontinue medications autonomously without having to refer or make a recommendation. And we realize that that is not applicable at all practice sites across the U.S. In summary, we saw a significant increase in the proportion of veterans with controlled blood pressure from the baseline through the intervention period, and a significant decrease in systolic blood pressure for the majority of enrolled veterans. There was a non-significant decrease in diastolic blood pressure for the majority of enrolled veterans, and no significant differences in the proportion of veterans considered adherent to their prescribed antihypertensives. A second phase of the project is currently underway, so we've enrolled more veterans from multiple providers into the same SMA model, and the data that we gather from phase 1 will be assimilated with phase 2 to increase our sample size as well as the length of the project to better determine the effects that SMAs may have on medication adherence. We also hope to develop a tool for providers that would be an evidence-based treatment algorithm to help improve the management of hypertension in our healthcare system. So limitations of the project include the fact that we excluded second-line blood pressure medications from the PDC calculation, so things like clonidine and hydralazine that some of these veterans with uncontrolled hypertension were already receiving was excluded from the PDC calculation. So they may have been adherent to those medications, but we didn't determine that. There was a small number of veterans enrolled and a short duration of the intervention period. I would like to acknowledge all the providers who made the SMA a success, with special attention given to Dr. Lindsay Neighbors, Dr. Addison Reagan, and Dr. Mitch Robinson. For a self-assessment question, what are the strategies and barriers for the implementation of a pharmacist-run SMA? Those were presented prior, and they're listed again here for you. And these are my references.
Thank you so much. Excellent presentation so far. And we are halfway through this program. We will take a 15-minute break at this time. We'll put up the time on the screen, so when we will reconvene at 3 o'clock Central Time. So thank you so much for the first two presenters, and we will take our break now. Welcome back from the break. Our next two presenters this afternoon, the first one will be Dr. Frances Cohenauer, co-owner and clinical pharmacist with Chad's PAYLESS Pharmacy in Florence, Alabama. Frances?
Thank you very much. I'm very happy to be here today to talk with all of you about pharmacist-led diabetes education, management, and training. So I do have a disclosure. My pharmacy, Chad's PAYLESS Pharmacy, has received grant funding from the Alabama Department of Public Health to help fund and begin our diabetes education and training program. The objectives that I would like to cover today through our discussion include describing the pharmacist-led diabetes self-management and education, and describe the accreditation process for pharmacist-led DSME. A little bit about me. I am a 2010 graduate of Samford University's McWhorter School of Pharmacy, after which I completed a PGY1 community pharmacy residency with UNC at Chapel Hill, with Moose Pharmacy as my practice site. I am currently the Director of Clinical Services at Chad's PAYLESS Pharmacy, and I am a residency preceptor and student preceptor. Our pharmacy was established in 2010 and is located in Florence, Alabama. We have a variety of clinical services that we offer to our patients, including medication therapy management, biometric health screenings. We offer travel and routine immunizations. We offer Part D plan comparisons, medication synchronization, as well as adherence packaging. And we have an AADE accredited diabetes self-management education and training program. I know we've covered a lot of information about diabetes already from our first fantastic presenter, but just as a little bit of a refresher in case you forgot over the break. As of 2010, 22 million people in the United States have been diagnosed with diabetes. Approximately 90 to 95% of those are diagnosed with type 2. There are long-term micro and macrovascular complications with this disease. Diabetes remains the leading cause of new blindness, renal failure, and non-traumatic amputations in the United States. 1 out of 10 healthcare dollars is spent on diabetes and complications. Education about disease and self-management behaviors is necessary to reduce the risks and complications with diabetes. With appropriate education, training, and support, patients can enhance their knowledge and skills to properly manage their diabetes and prevent or reduce many complications associated. So what role as pharmacists can we play in diabetes education? Well, we are the most accessible healthcare professionals in most communities. Patients with diabetes see their pharmacist 7 times more often than their primary care provider. Only 30% of patients receive formal diabetes education, so pharmacists are in a prime position to provide diabetes education since they see us more often than any other provider. We have the opportunity to positively impact patients that we see on a continual basis. Studies have shown that pharmacists that are involved in diabetes education can improve medication adherence, treatment outcomes, and quality of life. Common practice sites for pharmacists providing DSMET include community pharmacies, ambulatory care settings, hospitals, long-term care facilities, and rehab facilities. Pharmacist involvement has also shown cost savings for the healthcare system. According to the American Association of Diabetes Educators, or the AADE, there are 7 key self-care behaviors necessary for self-diabetes management. And these 7 self-care behaviors are listed here. They are healthy eating, physical activity, taking medications, monitoring, problem solving, healthy coping, and reducing risks. Each of these behaviors should be included in a diabetes education curriculum. The American Association of Diabetes Educators has also identified 6 standards of practice for the pharmacist's role in diabetes education to ensure quality and accountability in the provision of these services. As you will see, this process contains elements that we do every day in our practice while we interact with our patients every day. Standard 1 is assessment. This assesses the patient as a whole in a medical way. We utilize information that we've gathered from our referring provider, such as labs and medical history, in combination with information we've obtained from the patient. So we will see current medications, their lifestyle, their diet and exercise habits, tobacco and alcohol use, current medical conditions, financial constraints, and it also gives us an opportunity to identify whether appropriate lab tests have been performed. This also provides an opportunity to identify opportunities for risk reduction with referrals, for example, eye exams, dental exams, foot exams, or necessary immunizations that they have not received. It evaluates patient medications to determine appropriateness of therapy in regard to recent practice guidelines. Finally, this standard also assesses the patient's ability to use testing supplies and adherence to medication regimen. This reminds me of a story for one of our patients that we've worked with in our education. We were assessing how they were testing their blood glucose, and our patient was using the same lancet without a lancing device and was using it over and over and over again. Not changing it out, she was just poking her finger with the same old lancet that was dull, and you could tell in her face that it was very painful for her to do that. So through this assessment, we were able to identify that, and then you could see in the future steps opportunities to educate and fix that behavior. It also gives us an opportunity to assess our patients and if they understand what their results mean. So, you can check a blood glucose and you can see a number, but you might not always know what that means. It also gives us an opportunity to assess our patients in their readiness to change and whether they're willing to adjust their current practices to improve their health. Standard number 2 is outcome identification. This is basically setting goals. It educates the patients to enhance knowledge of diabetes and its complications and to help them understand their desired outcomes. So this is where we teach them about diabetes, teach them about their concomitant diseases, as well as their complications. We help them to understand what kind of outcomes they should be achieving, and then we give them the opportunity to set their goals. It's important that we always encourage and support the patient's choice while giving them a full disclosure of what the potential consequences are for those choices. Finally, we can evaluate those outcomes and share those with other providers in the healthcare team. Standard 3 is planning. So we've determined all these outcomes and goals, and now it's time that we try to accomplish them. So in the consultation with the patients and with other healthcare providers, we can prioritize the identified problems, propose alternative treatment strategies, and this also helps us establish good working relationships with other providers. It helps us determine the most appropriate educational plan and medication regimen. And then most importantly, you have to explain the plan to your patient. You have to give them that opportunity to give them their feedback and let them know, because we of course want them to be involved in their care most importantly. Standard 4 is implementation. So now we have to put that plan into action. This is where we can counsel, train, and educate our patients. This communicates essential information to their patients about their medications and their diabetes devices. This reminds me of another story from a patient that was in our class who was using insulin pens, and they had put the pen needle on the pen, had removed the clear cap, and then was injecting it without removing the colored sheath that was covering the needle. So our patient was not receiving any of their insulin, and they were confused as to why their readings were so high and why their A1C wasn't being improved. And it was just this one, teaching them and showing them and working with them on how to best utilize their medications, and it can just create such tremendous results. This step is also where those self-care behaviors that we discussed earlier are going to come into play throughout this process. It also will help us to determine the patient's commitment to taking all their medications, performing their testing, and really getting involved in their care. Also in this standard, we get to use our motivational interviewing skills to help them, ask them questions, get them involved, use those things to really try to get them to become committed to improving their disease state. This also helps us to collaborate with other healthcare providers and refer to other people that are outside of our scope. For example, dietitians and some of those other providers that our first two speakers spoke about. Standard 5 is evaluation. So now that we've done all that, how good of a job have we done? So there's several different ways in which we can gauge if they've accomplished those set goals. There are quantitative measurements such as symptoms and laboratory measurements, A1Cs, any hypertension numbers, any of those numbers that we use to kind of measure. But then there's also qualitative measures such as, what did the patient learn about themselves in their journey? We had another patient who we found that after monitoring what he ate and then checking his diabetes, checking his numbers, that starches really made his numbers go up. And he could tell on nights where he ate a high starchy meal, he loved pasta, that the next morning his blood glucose was much higher than it normally was. So we recommended that he try a quinoa pasta, and that seemed to really help control and give him an alternative option so he could still enjoy the foods that he liked. But this is not only applicable to foods, it's also applicable to medications, physical activity, consumption of alcohol, or use of tobacco. Also in the evaluation step, it gives us the ability to assess the patient's ability to recognize and resolve adverse events. So in this time, if they experience an illness, such as they get the flu or have a cold or have a stomach virus, it kind of allows them to trial and error, be able to still manage their blood sugars and their medications while dealing with all these other acute illnesses. Standard 6, documentation. We've heard it once, we've heard it many, many times. If you didn't document, you didn't do it. For accreditation purposes, we must maintain patient charts, recording all this information about our patients. But it's also a really good way in which to share information with the referring provider or other members of the healthcare team. Now I'm going to talk a little bit about how you could get your program accredited. So accreditation is basically recognition. There are several CMS-approved accrediting bodies: the American Diabetes Association, the American Association of Diabetes Educators, and then the Indian Health Services. But unfortunately, that's a closed system, so we are left with the two, ADA and AADE, for accrediting our programs. Accreditation is necessary for reimbursement. CMS requires accreditation through either of these bodies in order to reimburse us for our services. But the national standards are the same for both organizations, and there are 10 national standards that we will go through. The two accrediting bodies, while very, very similar, have two basic differences. The ADA focuses on hospitals and health systems and is most appropriate for that setting, while the AADE focuses on settings that are community-based, such as pharmacies and outpatient clinics. Here's a comprehensive list of the 10 national standards. And each accrediting, like I mentioned before, each of these two accrediting bodies requires that each of these standards are met within the program, and you must provide documentation proving that. Standard number 1 is internal structure. This is basically the organizational structure. It's a clear structure that's documenting lines of communication from the sponsoring organization all the way down to your coordinator and members that are involved in actually carrying out the diabetes education. Also, they would like to know about the program mission and the goals. And then you need a letter of support from either the owner or the CEO of your organization. This was easy for us because if it's a small company, you just have the owner write a quick letter of support. But it could be a little more difficult for larger health systems or larger practices. So this just really ensures that these accrediting bodies know that you have buy-in from the top down on your entire organization. Standard number 2 is external input. This means that the program has a documented plan for seeking outside input. It consists of an advisory board that can have several different varieties of healthcare professionals. It's important to have patients involved. You could have patients that have been through your curriculum or patients that haven't, but it really gives a really nice element of grounding for your program. Some other options are other diabetes educators, other program coordinators, physicians, nurse practitioners, or members from academia. Standard number 3 is access. They want to know who your population is and any barriers that you may have in trying to provide education to your patients. And not only any barriers, but how you perceive to overcome them. You should be able to identify the special needs of your patient population, whether they're handicapped, if they're blind or deaf, if they have any transportation needs, and determine actions that you need to do to overcome any problems that may arise. This document may also need to include where and when the classes are being held and the resources that you will provide to your patients. For example, our classes are presented on iPads. When we submitted our documents to the AADE, they let us know that we needed to include in this access standard documentation that if someone did not want to use an iPad, that we would have alternative resources to provide the education to them, such as notebooks, or we have a TV screen that we can show the slides on as we go. So we just had to show a variety of ways that we could reach our patients. Standard 4 is program coordination. You must assign one program coordinator that has experience managing chronic disease, facilitating behavior change, or have prior experience with a program or clinical management of diabetes. They must receive a minimum of 15 hours of CE every year that is specifically related to diabetes education. The coordinator is responsible for planning, the implementation, and the evaluation of your education services. Standard 5 is any instructional staff. One must be an RN, an RD, or a pharmacist, and they must have training and experience in diabetes education or a certification such as a CDE. Again, they must have 15 hours of CE relating to diabetes education, and you must have a policy that says if there's patient needs that need to be met that are outside of the instructor's expertise or scope of practice, that can be provided for them. Standard 6 is the curriculum. There are curriculums that have been developed by ADA and AADE, and they are available at their websites to be purchased. The curriculum must adopt those principles of the 7 self-care behaviors that I mentioned towards the beginning of my talk. It has to be reviewed and updated annually as guidelines of management change, and they have to reflect maximum use of interactive training methods such as iPads or smartphones. For Standard 7, individualization, everyone has different needs and learning styles, so the program curriculum must be tailored to each patient's individual needs. You have to submit a de-identified patient chart with required elements listed on the AADA or AADE website. This shows them that you have done your due diligence to personalize the education for your patients. You also must develop an individualized education plan based on assessment and behavior goals. So, for example, a patient that's overweight is going to have a different plan and different goals than a patient who's not. So that individualization really helps tailor it and make it perfect for the patient you're trying to treat. Standard 8 is ongoing support. You have to have ongoing self-management support options, and you have to talk with those about your patient. It's also important to communicate these to the patient's referring provider. This really helps to get the patient to commit to their success long-term after they're out of your hands of having classes. Some examples of this are, subscribing to a diabetes magazine, joining a gym, tracking their steps with a pedometer, some things like that. Standard 9 is patient progress. So this is a collaborative development of goals and outcomes evaluated. The follow-ups for after they finish your curriculum can occur every month, every 3 months, every year, just dependent on your patient needs and how far they needed to come and how many of their goals they achieved while they were with you. The last standard is quality improvement, and the quality improvement is ideally proactive and not reactive. You want to try to make positive changes to your program even while things are going very well. You don't want to wait for something to go wrong before you make changes. To apply for accreditation, you have to submit a fee, a full de-identified patient chart from referral to follow-up, and then the process on how you will accomplish the standards. And each standard will have different documentation that you will need to submit. And as you see, there's the website for the AADE on where you can apply. And then there is the one for the ADA. And then if they have found that you've met all the standards, they will either conduct a phone interview or a site inspection. When we were applying for our accreditation, we submitted all of our applications. 2 weeks later, we were contacted about some missing items or some things they wanted to change. In our case, it was the access, in the access section with the iPads. Then after that, we had a phone interview, and it was very informal. They were very nice. You can really tell that they want you to become accredited. I think they really are invested in programs that are showing the initiative, and they want to have as many accredited programs as possible. And then shortly after that, we received our accreditation. So in summary, pharmacists, we really have a very unique opportunity to reach our patients, particularly with diabetes. Collaboration with patients and other healthcare providers is very necessary to achieve optimal outcomes for patients with diabetes. And accreditation, while it does require a lot of effort and documentation, it's very possible for pharmacists, and it is a very, very rewarding endeavor. I would like to give a special thanks to my pharmacy resident, Dr. Chelsea Leonard, for her help. And I think we're taking questions at the end, but here are some references. Thank you all very much, and now I will turn it over to Dr. Laird.
Thank you, Dr. Cohenauer. Our next presenter, our last presenter today, is Dr. Christine Laird. She is coming to us from the Gulf Coast Veterans Healthcare System, and we will turn it over to you, Dr. Laird.
All right. Thank you, Dr. McVeigh. So good afternoon. My name is Christina Laird. I'm a 2015 Auburn grad, and like Dr. McVeigh said, I'm completing my PGY1 residency at the Gulf Coast VA Healthcare Center, and I'm doing it specifically at the Joint Ambulatory Care Center located in Pensacola, Florida. So over the past year, I've spent a majority of my time in longitudinal rotations where we're managing care for patients who have type 2 diabetes, hypertension, anticoagulation clinics, hyperlipidemia, and really any other kind of chronic disease that primary care decides to refer to us, we can potentially manage. So luckily, I've had the experience of seeing firsthand the impact that pharmacists can truly make in the long-term outcomes of patient health, specifically related to type 2 diabetes. So today I'm going to be talking to you more specifically about clinical pharmacy specialist interventions and pharmacist-led ambulatory diabetes clinics. So before we get started, I do want to state that I have no financial relationships or sponsorships to disclose. And today, I'm going to be describing an example of diabetes care provided by pharmacists within the VA center that can also be cross-applied to many primary care settings, and then review a study that supports the impact of pharmacist-managed diabetes clinics and identify some of the collaborative drug therapy management legislation in the state of Alabama. So to get started, I wanted to orient you to our healthcare system and my practice site, and then describe our practice setting for diabetes care. So I work within the Gulf Coast Veterans Healthcare System, and we serve over 60,000 veterans every year. Our health care facilities range across 3 states, which include Mississippi, Alabama, and Florida. Our primary hospital is actually located in Biloxi, Mississippi. It's a 716-bed facility where we provide both inpatient and outpatient care to our veterans. We also have 4 community-based out clinics, or CBOCs, where we provide primary care services in Mobile, Alabama, Pensacola, Florida, Eglin Air Force Base in Niceville, Florida, and then also in Panama City. So Pensacola is actually the largest CBOC of these 4 outpatient centers, and we see more outpatients at this facility than the main hospital in Biloxi sees per day. At our facility, we have 14 primary care physicians, we have 19 specialties, and then we have at least 1 endocrinologist at any given point in time. And we have 4 clinical pharmacy specialists who are dedicated to either anticoagulation, diabetes clinics, lipid or general pharmacotherapy clinic, and then we also have 1 clinical pharmacist that specializes in home-based primary care for those veterans who are unable to travel to the facility itself for care. The way that the JAC organizes patient care is through the patient-aligned care system model, which is very similar to the patient-centered medical home that's frequently discussed these days. And it's primarily composed of an interdisciplinary team of providers that includes primary care, nursing, and there's at least 1 clinical pharmacy specialist per 8 primary care providers. So within this system, every primary care provider has 1 pharmacist that they can go to for any questions that they have about management with diabetes. If they have a patient who they'd like to refer, you're their pharmacist that they refer you to. And this team also includes any subspecialties like podiatry, optometry, and nutrition as well. So the idea behind PAC care is to place the patient at the center of care and to provide comprehensive, continuous, coordinated, high-quality, efficient, and accessible care to our veterans, primarily things that target management of chronic complex diseases, which include diabetes. So those final two goals are especially important for the role of clinical pharmacists in helping to provide complex chronic disease management. Within the PACT model of care, physicians refer their patients that are especially complex or need closer follow-up care to see a pharmacist by either appointment or by an appointment for their chronic disease care. And at these appointments, you have a clinical pharmacy specialist who operates as a mid-level practitioner who's operating under a defined, pre-agreed scope of practice that's signed off by the chief medical officer and other primary care providers at the facility, and they are providing direct patient care services, a lot of those services which we've already identified and discussed today in our previous talks. So within that scope of practice, our pharmacists help our primary care providers manage diabetes, hyperlipidemia, hypertension, pain. We do see anticoagulation patients, any other kind of general chronic disease state management we see in our pharmacotherapy clinic. We do manage hepatitis C patients, especially within our veteran health system. We also have pharmacists that are dedicated to seeing patients who have mental health conditions as well and helping them manage their therapies related to that. And then we have home-based primary care. So the goals of our clinical pharmacy specialist services are to improve patient care through the application of evidence-based medicine and safety, and then also in so doing, improving patient satisfaction through individualized patient-specific care. And then we also want to improve physician productivity and efficacy as well, and then also provide cost savings when appropriate. So within the diabetes clinic, our scope of practice allows us to initiate, renew, adjust any medications that the patient might be on. We can order any labs that are associated to monitoring those therapies or their disease state, and we can obtain, their patient history, do chart reviews, other labs like their C-peptide or a GAD autoantibody if we believe that the patient might actually not be a type 2 diabetes patient, might actually be a type 1. We can perform medication reconciliations, and we monitor, of course, for their adherence to their medications and then any associated adverse drug reactions that might be developing from their therapy. Additionally, we can conduct diabetic foot exams if you have certification to do so. You can make recommendations to providers to help manage other chronic disease states that are important to diabetes, such as hypertension. You can also provide new prescription counseling, refill counseling, arrange or schedule any kind of follow-up appointments with podiatry, nutrition. We do have a diabetes education course that's kind of taught by nutrition and pharmacy, so that's a really great opportunity to provide our patients education. And then we can consult them out to anybody else that we think would be appropriate, like wound care if they have a diabetic foot wound that they present with in clinic. So to give you an idea of the need for pharmacist involvement in primary care management of diabetes, I wanted to kind of give you a snapshot of diabetes in the veteran population more specifically. So in 2014, there were 6.6 million veterans who sought and received health care through the VA, and 26% of veterans have a diagnosis of type 2 diabetes, although that number is probably significantly underestimated. It is the third most common diagnosis among veterans, and at the JAC more specifically, we have 5,000 patients who have type 2 diabetes. That's 5,000 patients spread across 14 providers, so it's about 350 diabetes patients per provider, which is a hefty load to take on as an individual provider. Type 2 diabetes accounts for over a quarter of all pharmacy costs, and it's responsible for 1.7 million hospital bed days. There tends to be a higher prevalence of diabetes in the veteran population compared to the general population, and our veterans who do have type 2 diabetes, they tend to be older, have longer standing diabetes, they have more comorbidities that make managing their diabetes care a little bit more complex, and have lower sociodemographic characteristics. And despite these more complicated patients, using the PAC team care model has actually helped the VA score higher than Medicare on improving certain metrics like A1C and helping out with the number of preventative services that are actually offered to our type 2 diabetes patients, such as eye exams, lipid screenings, and other preventative services like vaccinations and things like that. So what do our pharmacists actually do prior to, during, and after these clinic appointments? Well, prior to the appointments themselves, we go through their record, their medical record, and look for any recent changes in health that might affect their affect or impact their diabetes care or management. When they're in clinic, we take vital signs like weight, blood pressure, and we counsel them on diet, exercise, drinking behaviors, any smoking habits. We do have a smoking cessation clinic that we can refer them to. Any other kind of preventative care that we feel they need counseling on. We perform medication reconciliations and address the causes of any hypoglycemic episodes that they might be experiencing as a result of taking their diabetes medications, and then review their blood glucose logs or meters that they bring in. We also will review their labs. Every appointment that we have with them, we do schedule labs prior to then so that we can track their progress over time. And then based off of those labs, we'll discuss any kind of medication changes that we think are necessary to implement. And then we'll provide typed instructions of that care plan, which is very important. And then determine an appropriate time for follow-up care with us, and then our clinic contact information, and then coordinate any kind of follow-up care that they might need with any other providers. So ultimately, we're there to help them achieve a very definable goal with glycemic control so that we can discharge them from our clinic or graduate them, as we like to say. Those goals can be very patient-specific when it comes to A1C, and depending on if they're having other complications like frequent episodes of hypoglycemia, we may adjust their fasting blood glucose goals and maybe even postprandial goals as well. But you can see some of the generic goals listed there on the slide. And we want to try, we make it a best effort to make sure that they're not having any hypoglycemic goals at all as well. We also set secondary metabolic goals that obviously will include being on a high-intensity statin. Depending on their lipid profile, we may also set goals for triglycerides, their HDL, and their total cholesterol as well. Other metabolic goals that we might be addressing with them include blood pressure goals, weight goals, and reminders about eye and diabetic foot exams. So at the end of the day, pharmacists are involved with diabetes care to not only help patients, but also our physicians. And at our facility, primary care physicians are tracked by metrics outlined on this slide. And pharmacists have a huge role to play in improving these primary care metrics for our providers. So they're motivated too to keep, get us on board and help them out because, like I stated before, they have very large patient censuses. So you can see some of the ways that they're tracked there. Primary care providers have a pretty huge task before them when it comes to managing very complicated, complex type 2 diabetes patients. And it can make it difficult to successfully manage these patients. Some of these barriers that make it difficult include having very short visit times. So every primary care appointment at our facility is designated a 30-minute appointment time. And some of these patients have problem lists that are 15 to 20 problems long. So that's 30 minutes to address 15 to 20 problems and a medication list that it can include anywhere from 15 to 30 medications. So there's a lot to address in that 30-minute time period. So pharmacists are crucial to helping manage some of these chronic disease states. So they do present with complex morbidities. They have growing patient censuses that they have to address. And then they do have less frequent patient contact between visits because they see more patients. Other barriers that require more follow-up and maybe some more one-on-one attention can include those posed by the patients themselves. So patients who have cognitive deficits that make it difficult to manage their diabetes, if they have any kind of psychological barriers such as depression, that can contribute to how they manage their diabetes. So they have poor disease state knowledge, poor medication knowledge, or no financial or insurance resources that can complicate their management as well. So now that we understand the reason for pharmacist involvement in diabetes care and have defined their role in that care, we can start to explore the impact on outcomes through the literature. So today I'm going to be talking to you about a study that I found in the literature that I thought mimicked our practice setting pretty well, and it's titled The Impact of Clinical Pharmacist Intervention on Diabetes-Related Outcomes in a Military Treatment Facility. So the setting of this study, it took place in the Womack Army Medical Center in Fort Bragg, North Carolina. It was designed to be a retrospective chart review. It was a collaborative practice model between primary care physicians and pharmacists, and the objective was to evaluate type 2 diabetes outcomes associated with care by a pharmacist, or that was managed by a pharmacist versus traditional management. It included 188 patients, and the primary outcomes that were tracked were the mean change in A1C, blood pressure, and LDL. And secondary outcomes that were monitored included the percentage of patients who achieved ADA treatment goals, and then inclusion criteria. Patients who were between the ages of 28 to 86 years old could participate in the study. They had to have had at least 2 A1C measurements and at least 1 A1C value of 9% or greater. So the study included 98 patients in the pharmacist cohort and 90 patients in the control cohort, and the baseline characteristics of the groups are shown here. There were no significant differences in the distribution of demographic characteristics between the two groups at baseline, and included individuals generally to describe the population. Most patients were generally over the age of 50. They were overweight or obese based on their BMI, and they didn't seem to have any most of them didn't seem to have hypertension or significant elevations in LDL, and they had an average A1C of 9%, and there was fairly equal distribution between men and women represented in the study. So here you can see the baseline and final primary clinical outcomes that were measured. There was a 1.6 reduction in A1C and the average final A1C of 7.1% compared to an increase of 0.8% and an average final A1C of 9.9% in the control group. The systolic blood pressure in the pharmacist group reduced significantly more than in the control group. However, this was not as large of a reduction in the diastolic blood pressure for either group. The LDL values decreased from 87.6 to 71.3 in the pharmacist group and from 109.2 to 104 in the control group. And on this slide, you'll see a summary of those changes between the two groups and their significance there. Ultimately, there were positive improvements noted in the pharmacist group for all the endpoints. As the secondary objective, that was evaluating the percentage of patients that achieved ADA treatment goals. Across the board, pharmacists saw larger increases in patients that were achieving their goals for A1C, blood pressure, and LDL compared to the control group. So there was a very real, measurable impact that they made. So studies like this and like the Asheville study that we discussed earlier are a couple of studies in an ever-growing pool of information that we're gaining about the impact that pharmacists can have on diabetes care and management to improve their glycemic control. And this makes collaborative practice in our state all the more important. I couldn't find a more updated map. This map is from 2012, but this is just showing us all of the states where collaborative drug therapy agreements are either allowed, restricted, or do not exist. Since 2012, there are only 2 states remaining that do not have these on the books on a state level, and Alabama is one of them. There are very good people who are working on it. That doesn't mean that this doesn't happen in our state. A lot of providers still have collaborative practice, but what it means for us realistically as practitioners is that if something bad were to happen, both the physician and the pharmacist would not be protected by state law. So it makes it even more important for us to pass this type of legislation in our state. So having these laws in Alabama are really important, primarily because we've seen through our other presenters that there is a high prevalence of diabetes in our state. We do have an overburdened healthcare system that has access issues to primary care. We have a recent reduction in the health budget that's only going to exacerbate that and make things worse. And there is limited access to primary care providers, especially in rural parts of Alabama. So we need people who are going to be able to be there, work with the existing primary care providers, or to fill those gaps in care when necessary. As we know, poor control with diabetes can lead to increased costs, secondary to the micro and macrovascular effects of uncontrolled diabetes. So nephropathy, neuropathy, retinopathy, diabetic foot infections, and cardiovascular disease can really increase costs to healthcare in our state. The most recent legislation for collaborative practice that was even read aloud in session was presented on April 14th of 2015. It was sponsored by Representative Ronald Johnson, and it was hoping to formally authorize collaborative practice agreements between pharmacists and physicians in our state. It was referred to the House of Representatives Committee on Health, and it kind of stayed there. It never left. And We do have a lot of organizations in this state, like the state medical associations are working with the pharmacy state associations to draft more legislation to discuss at future sessions. But the more people get involved, the more that they'll see people care about this issue and we need help. So get involved. We've already discussed some of the collaborative delegated functions that pharmacists can perform, so I won't reiterate those points, but you can see them again emphasized here. And of course, all of this stuff is dependent on, our training, education, experience, our certifications that we have, and of course, physician needs and willingness to participate in these types of agreements. So these resources I included as places that you can find really great information to help form business plans, draft support letters to your congressmen and representatives on a state level or even a national level to implement collaborative practice agreements. And so you have those at your disposal. And I also have a handout that gives a great summary on other literature. So if you need literature, primary literature, to help support those business plans, I'd be happy to send them to you.
And the health department has been really pleased to be a part of this presentation. We are fortunate enough that we have 4 excellent presenters with us today, and we have had a few questions that have come in. Ken, could you give us those questions?
Yes, sir. The first one is, I recently read a study about research currently being conducted on a smart insulin patch that could sense blood glucose levels and release insulin into the body. Can any of you tell us about any pharmaceutical advancements like this that you're aware of, and where you hope to see progress being made in the future?
Who would like to address that first?
I could take a stab at it. So one of the more recent advancements that they've seen with insulin is trying to kind of address the issues related to administration frequency that patients have to deal with. So newly developed insulins right now that are currently on the market include what they call ultra long acting insulins. And the original idea behind those insulins, although it kind of fell a little bit short of the goal, was to make it possible so that insulins would only have to be administered maybe once every other day. And while the half-lives for these newer insulins, like concentrated insulin glargine, for example, or Tresiba, they didn't quite, their half-lives didn't quite meet the mark for sustained glycemic control, so you still have to administer them at least once a day. The patch that you're referencing to, I have heard about that, and I think, ultimately the goal, that the patch is hoping to achieve would be ideal for diabetes care. If you have a patch that can automatically detect when you're going low and be able to administer, or when you're going high and be able to administer insulin in response to that, that would be, excellent, because it would more closely mimic how your pancreas works and responds to your blood glucose levels. So, basically getting some kind of pancreas mimetic would be, I think, the holy grail of diabetes care. So that's how I would answer that.
Thank you so much. And is there another question?
We do have another question. They say, can you tell us anything about how inhaled insulin works, and does it replace injectable insulin?
Does anyone want to address that?
Okay. I could take a stab at it too. Actually, there was an inhaled insulin developed many years ago. I believe it was over 10 years ago that it was developed, but it was actually a very cumbersome device, and it actually it wasn't as effective, and there was not much patient or prescriber buy-in for the device, so it actually just kind of dissolved into the market, and I believe they actually took it off the market because there was not much buy-in for it. But I think, with the advances over the years in just medication administration and the different products that are being developed, such as that patch, and also they're thinking about developing kind of like an external biologically engineered pancreas for type 1 diabetics. I think the technology has improved. I personally have not heard of or seen any of my patients with an inhaled version of an insulin, but I know that there are some in development that they're looking to try to hopefully get on the market in upcoming years.
I could
Any
add
other?
to that as well.
Please.
So the newer inhaled insulin that came out on the market, I think in 2014, it's called Afrezza. And so, some of the stipulations that came with it that they found from some of the clinical trials, they did see in patients who have reduced pulmonary function that Afrezza could actually, be damaging and further damage their pulmonary function for that medication. So there are some stipulations when it comes to contraindications, precautions, warnings with Afrezza, the inhaled medication, insulin medication. The other thing about the inhaled insulin is that it comes in very distinct quantities, and so unlike insulin or some of our other medications that we might be able to use in a more patient-specific way, the inhaled insulins, you can only give limited doses that are kind of limited based on how the insulin is packaged. So there's less individualized care with the inhaled insulins potentially.
Anyone else on the panel want to address that? Do we have any other questions?
Yes, sir, we have one more. Can DSME be taught using telehealth?
I believe it can. I believe it also is reimbursable through the Centers of Medicaid and Medicare. That is an approved way in which to deliver diabetes self-management education and training.
Any other questions? I really appreciate that question because we with the Alabama Department of Public Health have been interested for several years in telemedicine, and we currently have put 10 telemedicine units in rural county health departments, and our plan is over the next 6 months to add another 23 or 24 county health departments to this, and we're already talking with the VA facility about, and particularly they're very interested in counseling being done by telemedicine for individuals now that have to drive long distances, possibly, and I'm speaking particularly about VA, to get to a VA hospital, and it may not seem like that long a distance, only 50 or 80 miles, but if you don't have a car and you are very low income, 50 miles is prohibitive. So the idea that they could probably go to if they live in a rural area, to a county health department and see the practitioner that they wanted to and be taken care of there more locally, you can see that the possibilities of this. And we, of course, in Alabama are fortunate in that in the 67 counties we have a very nice county health department in each county. Some have more than one facility per county, such as in Mobile they have about 7 facilities. But the idea of being able to be close at home, if you have limited income, limited access to transportation, this would be just unbelievably good. So it's clearly coming, is how quickly can we implement it. Yes, sir. Another question?
Yes, sir. We've got one that asks, is it possible to get contact information from all the presenters?
Certainly. We can make that available on our website as a follow-up to this, and I can see why you'd want the information. They've been outstanding. Mm-hmm. I've been most impressed also. So I'm glad the audience has been impressed. Any other questions that have come in so far?
Yes, sir. Can you tell us a little about the difference between type 1 and type 2 diabetes and how they are treated differently?
Well, I think all of our presenters have addressed it, but who would like to be the first to address it?
I guess I could go since I did the first presentation on it. So there's an easy way to think about type 1 and type 2 diabetes. Really, it's more so in the management of type 1 and type 2 diabetes. An easy way to think about it with type 1 diabetes, your main focus on treatment is going to be with insulin therapy, whereas with type 2 diabetes, you have a little bit more flexibility as far as the treatments. You have oral agents, so it can come in the pill form. You do have injectable agents that are not insulin agents, and then you also have insulin. Now, as far as the anatomy goes, with type 1 diabetics, it's more so like an autoimmune disease, and so there is this big genetic component to it, and so it's basically where the immune system, it's basically where the pancreas is unable to produce insulin because the pancreatic beta cells are practically destroyed. Whereas in type 1 or type 2 diabetes, it's more so a development over the years, and you actually end up getting your body cannot use that insulin effectively, so it's not able to absorb much of the blood sugar that is consumed. But then eventually, over time, if your diabetes is not well controlled, your pancreas can actually just stop working, and that results in an insulin deficiency. So it's more of resistance that develops into a deficiency, whereas with type 1 diabetes, it's deficiency right out.
Yes, sir. Another question?
Yes, sir. What would a collaborative practice agreement look like for a high blood pressure?
Someone want?
I think there's a variety of ways that could present. In my practice setting, in a community pharmacy, if I were to have a collaborative practice with a physician on how to manage hypertension, it would definitely be between, obviously, patients that see that provider and then come and see me. There would be a set guideline of how we would manage, what kind of medications we would prescribe, monitoring, all things like that, things of that nature. I think there'd be a lot of monitoring involved, and then definitely a protocol set on how we could prescribe and in what fashion we would prescribe.
Yeah, and I think, in other settings too, I know that there's kind of a movement to get, a pharmacist in every primary care practice. So within the setting of actually working on site with a primary care physician, it could be as simple as them, meeting with their patient and then sending them down the hall to come see you, which is kind of similar to what the VA does right now. And then obviously all of the things that she discussed would also be outlined in that kind of agreement as well.
And to add on to your comment there, at the clinic that I did my residency at, the provider, whether it was a nurse practitioner or a physician, would actually see the patient, work them up, evaluate them, but then they would actually come to me, and I would actually be the one to choose what medication they would be started on and just collaborate with the physician in that fashion. So I think there's a lot of varieties and ways to create some type of collaborative practice and focusing mainly on hypertension.
I think another good element that pharmacists could bring to it is lifestyle modifications and disease state counseling. Oftentimes, as she's discussed, there's only sometimes limited amount of time to have a patient visit with a primary care provider, and a lot of times the chronic diseases can tend to be overlooked as far as really discussing about what is going on in their body and how what they're doing can impact how their disease state responds. So I think that would also be another integral part in a collaborative practice, is to have a very strong and heavy lifestyle modifications counseling portion to that as well.
Any other questions? Well, our time is just about up here. Again, it's been an honor to the health department to bring these outstanding presenters here. The fact that we had over 300 practitioners pre-register for this course, and being able to share the quality of information and the potential being so great that we are talking about. We know we have many restrictions in the state of Alabama, and we're not blessed in many ways, but the quality of providers that we have, and it's just, we know that the future is very bright, even with our limited resources. So with that, the Alabama Department of Public Health is pleased that you were able to be a part of this with us. And thank you again. Have a nice day.